It's our final session of the Cardio Echo Tackling Type 2 Diabetes series. I'm Jessie Lewis, the clinic coordinator, and I'm going to go ahead and go through our typical reminders, and then I'm actually going to turn it over to Dr. Rao, who's going to give us a little bit of an update on our fall clinic.
Thank you, Jessie. And I want to first of all, thank everybody who has participated in ECHO in this series and many people in your institutions who've participated in past series as well. That they've gone remarkably well, and it's a privilege to have you as participants. So this fall, our series is entitled, Your Patient with Diabetes at High Risk for Heart Disease, a series of case discussions. So one of the limitations that we've found in the ECHO curriculum over the last couple of series is that we spend a lot of time on didactic information, and the cases wind up being so interesting, not just in terms of their medical issues, but in terms of what they're like as people, that I'm craving for more every single time. And of course, we run out of time because ECHO is designed to be inserted basically into your busy day. So we're going to change the format significantly. We are going to focus upon the case discussion. And these cases will be compiled in advance with a specific theme. So for example, it may be a theme of newer pharmacotherapies. It may be a theme of poor health literacy or some sort of socioeconomic challenge that is common to the two cases we'll discuss every week. We'll begin with a very short didactic. And the way the didactic may work, we have expertise from people like Dr. Dungan, et cetera. They may start by saying, well, this is a really interesting lady that has had diabetes for a number of years, and suddenly her control seems to have gone downhill. And we'll talk about why in a moment. But before we get to that, I just need to go over some basics about GLP-1 agonists. And she may do that with a few slides, or I may do that with a few slides. And then move on. And the reason we want to do that is we want everyone to have a common understanding of the basic medical information that pertains to the case. And it may not be medical information. It may be, what does Medicaid cover in terms of home blood pressure, home blood glucose monitors in Ohio, for example, so that we're not spending a lot of time on those specific questions. We could talk about, well, what is this person really like? What's their home like, situation like? What are the challenges they face? Because we are, mandated to discuss some of the socioeconomic, some of the psychosocial issues that come up with each case. So that's the format we're going to take. This is the first time we're doing it, but it is a common format in other ECHO programs around the country. So I'm very excited about it. I've had an interest in case-based discussions for more than 20 years, wrote a textbook about it, and then the whole movement seemed to die out in the early 2000s. So I'm excited to re-engage with the whole concept once again. So I'll stop there and see if there are any questions about our format this fall.
Gautam, I would just add that the other thing that's really of interest here, I think, is this kind of the focus on cardiovascular risk factors in general. And so hopefully we can get into some more details on some of the other comorbidities that occur along with diabetes.
That's an excellent point, Kathleen, and I forgot to mention that. So it's very rare that we treat diabetes in isolation of other cardiovascular risk factors, hypertension, dyslipidemia, obesity, and smoking, et cetera. So those will be taken in to consideration in concert. So this is not entirely a focus on diabetes, but we're looking at the whole person, not just from a medical standpoint, but from a behavioral standpoint, psychological standpoint, social standpoint. And so that's a very critically important point. So what I would encourage folks to do before we move on to today's session is to consider your participation in this series this fall. So even if you're part of this series, I think this is a great opportunity to discuss some of your more challenging cases, also contribute to the learning of the folks who are going to participate this fall. And if you know of others in your institution who are interested as well, please recommend this series to them. Thanks a lot.
Well, good morning, everyone. I'm Kathleen Dungan. I'm the facilitator for today. I'm endocrinologist at OSU. You've already heard from Dr. Rao, and I will be doing a brief didactic today based on your feedback from the survey from last week. and it'll be a little bit of a potpourri. And I'd also like to introduce our case presenter. Dr. Westcott, are you on? Oh, there you are. Would you like to just say hello?
My name is Sarah Westcott. I am an associate program director at Camden Clark, which is about 12 miles on the side of, across the river from Ohio. I originally signed up for this and was at an Ohio-based critical access hospital in Marietta when this first came out. So I'm happy to present today.
Great, welcome. Okay, so here are our disclosures. These were sent to you on Tuesday by Jesse. So today we're gonna talk about both microvascular complications and a couple of other topics that came up in your feedback from last week. And so these are our formal objectives. Just review the initial approach to identifying and managing microvascular disease. We will also discuss approaches to prandial insulin with meals. And then finally, review a cost-conscious approach to glucose-lowering medications next. So I just wanted to start off here with, believe it or not, this is a simplified version of the comprehensive care recommendations in the American Diabetes Association guidelines. They're similar this year and last year. And you can see that this is just kind of an overwhelming sort of checklist. And I did, kind of condense some of these categories down a little bit for you, but you can see here, just what it takes to really get at a comprehensive medical evaluation. Many of these components can be done by the members of your team. So I think that's really important to consider when building your overall clinic structure. And I don't want to go through every single line here, but you'll also see some recommendations for what should be done at follow-up visits. And I think telehealth has made that a little bit more challenging to really determine what can be done at what visit. So maybe in the future, we'll see some changes there. And then what should be done on an annual basis. And some of that might change based on the characteristics of your patients, of course, how sick they are, how many comorbidities they already have, and what you're actively managing. So I'll start off with just a little bit of background again on the major microvascular complications, as we don't get into those very much when we're focusing on a glycemic control. And this is the first we'll talk about neuropathy. Really, the assessment should occur at least annually. And if someone has known neuropathy or high risk foot, it's suggested to look at their feet every visit. In terms of screening for neuropathy, our physical exam components are pretty rudimentary, aren't going to catch neuropathy until it's pretty more advanced. But you can consider a couple of components, temperature or pinprick to kind of evaluate the small fiber, and vibratory sense to evaluate large fibers. It turns out the 10-gram monofilament, really the utility for the 10-gram monofilament is to identify a foot that's high risk for ulcer or amputation, and not necessarily part of the the neurologic exam to identify neuropathy per se. And again, a good half of cases are asymptomatic. And if you strongly suspect a neuropathy, particularly given the right circumstances, it very well could be. And neuropathy can occur even at the time of diagnosis or even prior to diagnosis in people with prediabetes. So it's felt to be a fairly complex multifactorial pathophysiology. And then in terms of management, foot care, of course, is really important. I won't go into the details there. And pain management or symptomatic therapy if the patient has intolerable symptoms. Keep in mind our FDA-approved medications are pregabalin and duloxetine, but of course there are a variety of other agents, including tricyclic antidepressants, that are used. In terms of nephropathy, the annual screening begins at the time of diagnosis, but of course there could be other factors that can influence the presence of nephropathy prior to diagnosis. And of course, nephropathy can occur with the classic scenario of developing albuminuria, and progression of albuminuria or chronic kidney disease can of course develop because of other multifactorial risk factors without albuminuria. So for people with diabetes, we screen with the some assessment of urine albumin, as well as the serum creatinine and EGFR. And if there is nephropathy, keep in mind, in addition to the the ACEs and ARBs, it's now recommended to use an SGLT2 inhibitor, which has the highest level of evidence for protection of progression of renal disease, particularly in the presence of concomitant albuminuria. And GLP-1 could be considered, although the evidence is definitely less robust and seems to be heavily influenced by reduction in albuminuria as opposed to hard renal outcomes like doubling of creatinine and progression to end-stage renal disease. There are some considerations in terms of dietary protein. I would probably bring in a renal dietitian if a patient develops more advanced renal disease to assist with that. And then in general, recommending referral to the nephrologist in more advanced cases of EGFR less than 30 or so, or if you've got somebody who's got just kind of a rapid progression or really isn't fitting the profile, and determining possibly other etiologies. And then finally, I will quickly review retinopathy. Retinopathy is classically influenced by all of the ABCs, your A1C, blood pressure, and lipids. And so really all of those risk factors should be optimized to prevent and slow progression. And screening occurs yearly and every 1 to 2 years, otherwise if no known retinopathy. And in particular, it's important to remember that screening should be done early in pregnancy and every trimester. And so that's something that's not always well appreciated. There are some more advanced therapies that you will see. Sometimes the notes look like alphabet soup. So PRP, meaning pan-retinal photocoagulation for persons with high risk proliferative diabetic retinopathy, and some of the more severe non-proliferative diabetic retinopathy, and then more intravitreous therapies like EGFR agents are generally used for proliferative diabetic retinopathy and macular edema that is affecting the central the fovea. Okay, so now getting to our second objective, which was to really describe further the use of prandial insulin and how you might implement that. This is a simplified version of one of the diagrams that you might see in the ADA guidelines. And we've spent more time discussing injectable agents prior to bolus insulin, but didn't spend as much time on this component. So we did get some questions about that in our feedback. So basically, after starting basal insulin, in the guidelines, and I think it just makes sense based on a host of clinical trials, that you first want to consider whether or not the person is a candidate for a GLP-1 if they're not already on it. But if you're kind of following it to a T, that should already happen. And then adding a dose of insulin at the largest meal. And so where did that come from? I will discuss that momentarily. In general, that dose, I usually just start a set meal dose, 4 units, but you can do a weight-based dose or some percentage of their existing basal dose if they're on a really big dose of basal insulin already. And if they're maybe a little bit closer to goal as opposed to being really far from their A1C target, you might reduce their basal insulin. And then another option might be to use premixed insulin. And depending on what their eating habits are like, generally somebody who's having 3 meals a day will split that dose 2/3 in the morning, 1/3 in the evening. So for those patients who are not reaching goals, then you can add insulin sequentially to other meals during the day and using those same parameters, and then titrating according to the 2-hour post-meal glucose. So if you start off with just one meal, I think it makes it conceptually more easy to just, okay, titrate that dose to goal based on their 2-hour glucose level. So getting at this question, okay, do we start with 3 meals or 1 meal? So this is one of a couple of randomized controlled trials that were done asking this question. So they had patients that they had this pretty long run-in so that they could optimize their basal insulin, and then either started them on prandial insulin with their largest meal of the day, or started on all 3 meals and then followed them. And you can see here in red is the baseline. So those patients who started on 3 meals, they did quite well, reduced their A1C from average of 8.5 to 7.7. And then in the other 2 columns are patients who were either on metformin or sulfonylurea in addition to basal insulin, and they started stepwise prandial insulin. And so you can see they had maybe not quite as robust A1C reductions, but it was not considered statistically or it did not surpass the non-inferiority criteria, meaning that essentially it was clinically similar in A1C reduction. So on average, you can get about half of people to their goal with just 1 additional insulin injection per day. So it is a nice stepwise approach. And then in terms of weight loss, when you use this approach, or I'm sorry, not weight loss, but weight gain, you do see less weight gain, especially if they have metformin on their background therapies as opposed to sulfonylurea. So there may be some other potential advantages, possibly also minimizing insulin doses. And then the other potential advantage is, I guess, that just kind of emphasizes this idea of maybe trying to wean them off or take them off of their sulfonylurea. So what about sliding scale? First of all, it's ineffective as monotherapy. It's really a reactive strategy. So you won't really find sliding scale in the ADA guidelines, even though it's used really broadly. We've got lots of studies in the inpatient setting that really demonstrate the ineffectiveness of sliding scale when used as monotherapy. So the other issue that I have personally is that sliding scale is a very imprecise term. Nobody knows what it means, and a patient can't tell you how much they're taking. So I try to separate it out as and call it correction insulin or their sensitivity. It may be useful in some patients in addition to prandial insulin. So if they can demonstrate competency using a teach-back method, not just do you understand, but show me what you would do in this situation, and with education, because it does add a layer of complexity. Many patients can actually do this very well, but many cannot, and it's not always easy to know. There are other tools like smart insulin pens that really aren't covered by Medicaid, but could be an option in some patients. Having really good educational tools. There are some formulas here in case you're really a mathematical, they're just sort of approximate and give you a kind of a starting place. Occasionally I'll have a very mathematically motivated person who wants these more advanced formulas. The first is how to calculate their sensitivity. So how many milligram per deciliter do you expect the glucose to drop with each unit of insulin? That's really what the sensitivity is. You take the 1800 divided by their total daily dose. Occasionally a patient can do the second formula, not very commonly, but this is really the basis for any of the insulin calculators that are out there. Taking the, whatever their correction dose is equal to their current glucose minus their target divided by their sensitivity. It's not difficult for us as providers, but most patients won't do that. So what about carb counting? So again, in theory, it really makes a lot of sense. And when done well, it offers a lot of advantages. But so this is one of a couple of different studies out there that randomize patients with type 2 diabetes to carb counting or just simple meal dosing. Now, I must say that in this study, simple meal dosing really wasn't simple. It wasn't just a set meal dose. What they said was, give 50%, split the total daily dose of prandial insulin up according to meal size. So it does rely upon a patient to have a similar pattern of, okay, supper's the largest meal of the day, breakfast is the smallest meal of the day, or something like that. But you can see on the panels on the right that the A1C reduction was identical. The self-monitored glucose profiles were almost identical. Hypoglycemia was pretty similar. So that was something that was surprising to me. I think people learn to eat to maintain and avoid hypoglycemia, or at least overt hypoglycemia. The only potential advantages is less weight gain, and there's less insulin requirements. So I would suggest for most people that the strategy of carb counting could be transitioned to more of a carb awareness strategy. They either can use consistent carb meals or kind of consistent portion sizes if they're needing prandial insulin. In general, the ADA doesn't recommend any set number of carbs per meal. But if we're going to kind of recommend something, this can be individualized. But in general, I might suggest 45 grams for women, 60 grams per meal for men. Or you can use a big meal, small meal strategy. If you're going to have a big meal, take this much insulin, small meal, this much insulin. And for those patients who are really more advanced and astute, you can calculate a carb ratio. There are some patients that do that and prefer that, but that's going to need to be done in conjunction with a diabetes educator. And then thinking about how to optimize basal bolus insulin, really some of the things that I can't emphasize enough are making sure the patient's actually taking what they say they're taking, understanding what are some of those barriers before you just keep increasing the dose. In particular, there's a tendency to just keep titrating basal insulin to some ungodly amount without understanding what the patient's doing at bedtime or overnight that might be influencing that fasting glucose. Referring them to diabetes self-management education, using insulin-sparing medications when you can, helping the patients with managing activity and snacking and things like that. If you need to use insulin analogs or ultra long-acting insulins, which can minimize the risk of hypoglycemia. And then there's some more advanced things like concentrated insulins and other devices that you might just want to refer out. And then finally, what if cost is a major issue? Well, if you recall from the ADA guidelines, there are these pillars outside of whether or not a person has cardiovascular disease that are important for determining really kind of what is the hierarchy of glucose lowering therapies. Cost is one of those pillars. Really, these are the drugs out there that are generic. So metformin or sulfonylureas, thiazolidinedione, primarily pioglitazone. There are a few strategies that can be used outside of that, but it remains very challenging. I won't promise you that I have any quick fixes or straightforward answers. And then if you need to advance, then you can go on to some of the more less expensive insulins that might include NPH or 70/30, not the analogs. Again, here's a simplified version of the ADA standards of care. Again, these two main branch points: does the patient have cardiovascular or renal disease? And if not, then go to these other pillars. You'll find that many of these agents that are in the low cost zone here also have other advantages like weight loss or protection from hypoglycemia. So what are the things? First of all, what's on Ohio Medicaid's formulary? So for our basal insulins, we have Lantus or Levemir, and step therapy is Tresiba. So if they've failed for whatever reason that basal insulin, you can see the other sort of preferred agents. The glynides tend to cause less hypoglycemia and are more flexible, particularly in somebody who is not a regular eater than maybe sulfonylureas. And maybe if you're really worried about, like if they have renal failure or something, you might go with a glynide before you would use a sulfonylurea. They tend not to be quite as cheap, even though they are generic. And then step therapy for the other agents, which tend to be more preferred because they don't cause hypoglycemia or weight gain, are shown there. And so other considerations, if they have no insurance, there's often manufacturer programs that they can qualify for, assuming they have citizenship. If not, then you're relying on other kinds of programs. Copay cards are just that. They used to be, okay, no strings attached, just take a prescription with your card with you to the pharmacy, but in many cases now you actually have to have some kind of coverage, and then it helps cover the gap. And that's why they're called now copay cards, but they can be very valuable in those people who have private insurance, not Medicare, Medicaid, and need to kind of help cover those high copays. Cheap insulin is available at some pharmacies, namely, I will say Walmart, and I think Costco. You can get for whatever reason, I think complex reasons, $25 a vial for NPH or regular insulin. And then the strategies would be needed, of course, to make sure that those are used as safely as possible, because you do increase the risk of hypoglycemia. Also, regular insulin needs to be taken 30 minutes before the meal. If you have an FQHC or 340B programs, I tried looking this up, what is on those formularies. I couldn't find it, but I do know that liraglutide and there's some basal insulins that are available through these programs. So even if you, don't qualify for, Medicaid or other kinds of programs, you can still get these medications. And so my understanding, and many of you, I'm hoping that some of you could possibly share in the discussion your experiences with those, but I don't believe that you have to have any other qualifications. It's really more the clinic that has to meet the qualifications for that program. And then finally, Medicare remains one of the more challenging in terms of medication coverage because of patients getting into the donut hole. However, Medicare does, in theory, have good benefits on their medical benefit for glucose monitoring strategies. So even if I've got somebody on metformin and a sulfonylurea, oftentimes, insulin, I can often get them on a continuous glucose monitor. Okay, so I will open that up to discussions, any further questions. And again, I'd be interested in learning more about what your experiences with these 340B programs.
I just have a quick question, Kathleen. Are continuous glucose monitors covered by Medicaid?
Yes. However, the criteria for getting patients on these devices has become more and more strenuous, and something that actually we have an ongoing dialogue, and I think is something that over time is going to be made more straightforward, at least. So for Medicare, you have to be testing 4 times a day, and there is really almost no exception in that. You have to be testing 4 times a day. There are some other stipulations for Medicaid. One of the new stipulations is that you're meeting with a diabetes educator, and for ongoing use now kind of requires an annual visit with the diabetes educator. So that's one of the more challenging pieces. Got a couple comments in the chat here. 340B program is great, yeah. And my understanding, if you're using a 340B, that you have to actually be in the clinic. So someone outside of the clinic, a specialist or whatever, can't prescribe a medication for use with that program, even though the patient maybe have a provider in that clinic. Is that right or no?
Kathleen, can you talk a little bit about the patient that is having different meal times, like wakes up at different hours, may have just 2 meals a day, but it's not always the same time, and you're about to start insulin or prandial insulin? How much do you work with allowing the patient to eat at different times versus, how much energy do you spend on getting the diet times around the same versus trying to accommodate their schedule and do, sort of a prandial insulin?
Yeah, well, that's one of the beautiful things about prandial insulin is that in theory, as long as you don't have them on an exorbitant dose of basal insulin, that they should be able to vary their meal times as they like, because they just take their insulin when they're eating. And so we can have that discussion as that is one way that can help patients maybe even offer more flexibility. The struggle is when they're on a pre-mixed insulin, is that there's just not really a great way to handle that. I mean, you can do 3 times a day 70-30 insulin, but I mean, from my perspective, oftentimes that sort of defeats, I mean, you might as well just do basal bolus, although maybe you can save one injection per day. So yeah, definitely they have more freedom. But the danger is just kind of if they're already on a big dose of basal insulin, you're going to have to be more careful then about how that's how their total daily insulin is distributed.
Sorry, I'll have one other question about the sliding scale and regular. So I have patients that will sometimes come to me from endocrine on what they call a sliding scale insulin, but it's really prandial insulin, but with a sliding scale, right? As opposed to like sliding scale that they're trying to address after the meal, et cetera. So, I know you on your slide, you talked about sliding scale, which was more reactive. And to me, it's, I think the endocrinologist set up the sliding scale as a prandial insulin that wasn't meant to be reactive. So yeah, I don't know if you want to talk about that versus just having a fixed insulin, like small meal, big meal insulin, if that matters, and what you would recommend there. Is one better than another? And if there are, how do you set those up correctly with patients?
Yeah, it can be very confusing because the patient doesn't know. I mean, really, if you ask the patient, they'll say, "Well, it just depends what my sugar is," and it can be tricky to really understand what exactly they are taking. But it's a hierarchy, right? So the sliding scale piece, strictly speaking, is a correction factor, a sensitivity factor, and it does not include the prandial component. But many people do sort of lump it all together and just call it sliding scale. So really what's more effective is to do the prandial insulin. And then if the patient is capable, then you could add that sliding scale or correction insulin on top of that if their glucose is high. And it all should be given pre-meal. So post-meal dosing, the cat's already out of the bag. It takes, you need a good 15 minutes before a meal, especially in someone who's really insulin sensitive. So, start off with a prandial insulin, and if the patient is capable, then you can add that correction factor on top of it. And if I were going to choose between one or the other, the prandial insulin is going to win out, as long as I have some sense of that the patient has some understanding of carbohydrates and isn't going to just kind of have a salad at one meal and have a bowl of pasta at the next meal. So the education there is just so critical. We are right on schedule to be able to go forward with our case.
Right now, they are actually going to the house and making sure he takes all of his blood pressure and his diabetes medications. But, I don't know how much control we're going to get with just, those 3 medications right now.
And here's a comment from Chris Taylor. I don't know if you can see that. Does he have technology access that would allow his family to video chat?
I mean, he possibly does have that kind of, but whether or not he would remember to do it, is a whole nother aspect, I'm sure that if somebody was there to make him do it, but I don't think he would. I really don't. I think he spends most of the time he's very well nourished. Like if he could go out and walk to the store himself, those kind of things, but to remember to cook good meals or to put things away or,
Yeah, I wonder if maybe Chris, you could elaborate on that. I think, were you thinking that the family could just video chat him and watch him take his meds?
If it was a hassle of the going over, checking on him for a family member, but the ability to kind of call periodically, have a set scheduled time where it becomes a little bit more of a routine, it might help overcome some of the potential cognitive challenges you have with the TBI. But if it's a concern about, they came in and cleaned and found his medications later, but if they could check in on them daily or at least a couple times a week, instead of having to go over, you could set up a routine video chat that basically someone's calling and saying, so are you taking them? Let's watch you take them. Let's identify what the problems are. That it might create a little bit more routine, help them stay involved without it being such a kind of travel burden.
And I think they're all fairly close in proximity to him. But yeah, I'll bring that up with the PCP and just something else to bring in clinic, because the family was also very interested into getting him up to like, I think Cleveland for like the TBI clinics and those kind of things to help with cognitive impairment and memory.
Yeah, that's a great thought. Yeah. Kay Hoops had a really nice, really interesting comment. Can you elaborate on that? An alarming pillbox?
Yeah, at the VA, we often use alarming pillboxes for patients with memory issues or some type of cognitive ability, or someone who just says, I never remember my pills. It's set up similar to like the 4x7 grid, but it has alarms that you can set. So at 9 a.m. every morning, it goes off and says, take this box.
Really?
Whatever's in that box is what he would just have to open and take. So if the family could set it up ahead of time, he just needs to know when that alarm goes off, I take what's in that box. I don't know if that's something that would trigger enough of a memory, but some of our guys that tell us, I would take it, I'm not against taking it, it's just I can't remember.
Yeah.
That's sometimes what I go to.
That might be a really good idea for him, because I think I just don't think it crosses his mind to take the medications. I don't think he's purposely not taking anything. He was the most compliant patient at the hospital, very personable, like nice. I just don't think it crosses his mind. So yeah. That's why I don't know if the video chat will work, because I don't think he'd even think to do it, even though he did it the day before, that repetition isn't there, like.
Mm-hmm. So where do you get those? Can you get those at a pharmacy?
Yeah, I don't have like a certain brand or anything. I can certainly find out what the VA uses brand wise. I do believe they're a little costly. So it's probably $40, $50, maybe even $60 to get one outside. I'm unfortunately blind to that VA benefit. Of course, they'll just send it if they find they qualify, but they're certainly available.
Mm-hmm. And Jim Warner had some comment. Yeah, how do you get the family engaged and so that the patient is not feeling like they're under attack and being just watched? And do you want to comment on some of those issues, those dynamics that might come up?
Sure. Yeah. In developing behavioral plans for patients with traumatic brain injury, cognitive impairment, one of the principles is it's really important as much as possible to engage the patient directly in developing that plan. So it's their plan. It's part of what they want to have happen as well. And they're not just being monitored and controlled by other people, which they may naturally resist. Because they may have bad experiences from that in the past, and no one at any level of cognition really wants to be controlled by other people on a daily basis. So engaging them has been shown to be pretty effective. And then there's a whole field devoted to behavioral therapy of patients with traumatic brain injury and cognitive impairment, but that would require really being placed in a home, for example, with professionals who are constantly monitoring antecedents and consequences and shaping behavior and doing all the things that are necessary for behavioral interventions. But from the family, at a bit of a distance, I think engaging him in developing a plan, and it's his plan, it may be, helpful and maybe the best way to go about doing that.
He's really a go with the flow. Like, when I talked to him about going and getting some rehab, he was on board as long as his nephew was okay with it. He didn't resist a lot. And I think it's because they've given him a lot of autonomy. Like, he still lives alone. He's really pretty functional other than this short-term memory. And I don't think prior to, 2019, I think he was taking his meds really regularly, and then just something happened. I don't know if it was part of that stroke or just his memory loss got worse, and then COVID hit, and he, there wasn't as much outside stimuli and those kind of things kind of to help him. He just stopped taking his meds. I don't think, I don't know if he needed that daily, like that reminder from his clinic appointments, and he was scheduled for like telemedicine appointments, but like I said, he didn't do any of those during that time.
Yeah, Jim, I think that's a real question about engaging someone with short-term memory loss in a plan because they often forget they made that plan. So I think that's a great idea. I just know that like with our patients that have those memory challenges, they just forget making it. And I guess you could refer to it every single time and maybe print it out. I didn't know if you had other strategies you've used.
Well, I'm referring to a plan that would be made with family members to help monitor the patient.
Mm-hmm.
So the family members would be helping to implement the plan. This is in follow-up to Chris's suggestion about maybe family member monitoring via video chat or in person. So the plan would be reinforced every day by people who are, who are family members or friends or relatives who are engaged in implementing the plan with the patient. So the patient wouldn't be just on their own to try to implement a plan, try to remember all the things that are involved in that plan. But over time, hopefully they would, become very familiar with the routine that's developing. And I think that's a really important part of doing things with patients in this situation is developing a very predictable routine around certain things that are important for them. And family members are going to be key in doing that. And so what I'm saying is engage the patient in that plan and continually engage them all the way through.
Yeah, if they could kind of just, every day say this is what we have to do and some aspect, and I'll bring up like seeing if they could, set up a time, even it's just a call to remind him, this was the time you were supposed to take your meds or something like that. And then if we start the GLP-1, I know that the nephew would come and give it to him once a week, and he can just kind of reiterate that plan as well. Because I think he would do really well if there was just a routine that he knew of. I think that that's just the problem. I think that he's kind of has been doing the same routine for a while. It's hard to change.
Yeah, and certainly with the isolation he may have had all year, and maybe that is part of it.
Made his own new routine of not doing anything.
Okay, any other comments? Did we answer your questions, Sarah?
Yeah, if you can think of any change, are you okay? Like, so say somebody has some mild DKA, I really don't know, like the Jardiance is okay to restart and try again, and you think?
So, okay, I missed that part.
So he came in
oh
with,
yeah, okay, mild.
yeah, so he met all criteria for DKA. I held it while he was inpatient. I also held his metformin because I was doing some scans and stuff, but restarted everything but the Jardiance at discharge with the 70/30.
Mm-hmm.
And then when that didn't work, his PCP restarted all three because he was stable prior to, last year on all three.
Mm-hmm.
Which, his blood pressure was not doing very well. His blood sugars were all elevated. So he kind of was that borderline HHS versus DKA. So, but he did meet requirements. So that's why I had held it. But you think it'd be okay to continue that and just see how he does going forward? If he had another episode, that's when we would stop it completely.
I guess I would want to feel more confident that we have a plan that's working well. Although, even with mild DKA, it's still typically very mild if they have insulin reserves.
Yeah.
That's just me. I think you might get different answers from different people using them. But I guess I would tend to get his blood sugars down, make sure that he's able to have a kind of a plan ongoing, and then restart it. The metformin's fine. I think the risk of any kind of lactic acidosis is so critically low because his renal function's normal.
And when he came in, his lactic acid was fine, and and he did have some mild AKI, which it was all pre-renal, resolved really quickly with the fluids. I'll take that back to his PCP, and we'll go from there.
Right.
Thank you guys for talking to me about it. I like the idea of just engaging the family, and then maybe trying to get that alarming pill box, because I think that might help trigger some memory as well. That and a phone call, I think every day might really get a routine for him.
Great. Okay. Well, we are at the top of the hour. It has been such a pleasure, participating in this echo with everyone here. I just want to say thank you for all of your contributions, and I will turn it over to Jessie.
Great, thank you. I'll try and get through these pretty quickly. So just a heads up, starting tomorrow, the videos from this current series will be ungated. So you will not need to sign in with a specific account to view all the recordings for the series. And then next, you have 2 surveys in your inbox today. One is that typical post-clinic survey for feedback on this morning's session. That'll close tomorrow at 5. And then the other survey is our exit survey. It matches the needs assessment that you completed in advance of the series. And this just helps us assess kind of how you felt over the past 12 weeks and helps inform our future programming. So if you could fill that out as soon as you can. The deadline for that, though, is April 23rd, so there's a little bit of time. And then CMEs, you'll be receiving an email from myevaluations.com probably early next week. You'll receive an email whether you plan to claim credits or not. If you do need to claim CME credit, you'll register with myevaluations.com. And it's pretty self-explanatory. This is also due by April 23rd. And if anyone runs into any issues, please feel free to reach out to me. I can connect you with the CME office and we can troubleshoot. And then lastly, just wanted to reiterate about our fall 2021 Echo Clinic. The dates for that will be September 16th through December 9th. And that'll be the same time slot as this, so Thursday mornings from 8 to 9 a.m. And we'll have more details on the website shortly. Registration should be opening at the end of the month. And I plan to circle back with everybody about the surveys, and I will certainly let you know more details and registration instructions and when that opens. So with that, I'll just say a final thank you. Again, thanks for your time and participation. Hope this has been a great 12 weeks, and I'll be reaching out shortly with some follow-up. Thanks, everyone.
Thank you, everyone. Bye-bye.